Good day, dear great surgeons. Today we're gonna talk about upper limb anatomy revision, and it will be a crash course for the anatomy, specially made for our crash plan 90 days. Hope you are all well, and let's get together to crack upper limb, and it's one of the pillar chapters overlapping with the orthopedics, pediatrics, and the anatomy by itself is a pillar in the exam. So let's crack it together and focus on it. Regarding the upper limb, you have to be focusing regarding the fractures, the nerve injuries, and the muscle functions. Take care. Those are the main pillars regarding upper limb anatomy. The nerve supply in the exam is very critical, and you have to know the map and memorize it like your name. So, we have 5 fingers in each hand, and surprisingly, we have divided our hand into 3 fingers and 2 fingers. The big finger, the index, and the middle one, so the thumb, index, and middle one, are mainly through the median nerve, while the ring finger and the little finger through the ulnar nerve. This is roughly. But regarding the ring finger, where you put your ring after marriage, this ring finger is very special because it's where the conversion of the 3 nerve fibers sensation within this ring finger. The radial nerve, the ulnar nerve, and the median nerve. The 3 nerves supply the sensory supply for this ring finger. I don't know if this has anything to do with the marriage situation, but it's a great wisdom to learn from it. It's among the others, but yet it's the only combination of the whole 3 nerve supplies. The ring finger is the supply by the median, radial, and ulnar. So yes, you have no excuse to lose your ring from your ring finger, because you can sensate it with 3 nerves, the ulnar, median, and radial. These great surgeons, take care. We have interosseous muscles and lumbrical muscles. The lumbrical muscles are those who are divided lateral and median, the lateral by the median nerve and the medial by the ulnar nerve, and very important during your hand examination. But take care. The interosseous muscles are only supplied by the ulnar nerve, either the dorsal side interossei and the volar side interossei. We have palmar and dorsal. And remember this, bad dab, to know the action of which, because the bad are dab. The dorsal, abduct. The palmar, adduct. So, bad dab. Never forget this mnemonic for the action, and or the interossei by the ulnar nerve. So you can't open your hand or close your hand. You can't abduct or adduct your fingers from each other if the ulnar nerve is injured. While the lumbricals, in the other side, we have the lateral lumbricals and the medial lumbricals. The medial lumbricals are supplied by the ulnar nerve, while the lateral lumbricals are supplied by the median nerve. And by the way, the lumbricals are those who will extend your interphalangeal joint when the radial nerve is injured. So if we have our radial nerve injured for any circumstances, under any circumstances, we will still can extend our interphalangeal joint through the lumbricals. So the lumbricals can flex the metacarbophalangeal but extend the interphalangeal. Look at your finger and enjoy this miracle. So if we have the radial nerve injured and the ulnar nerve injured, we can still extend our interphalangeal joint of the index finger and flex the metacarbophalangeal joint, but we can't do anything with the ring and the little finger lumbicars. These great surgeons, we all know that the Zener muscles are the muscles of opponents, which is supplied by the recurrent branch of the median nerve. So it's all about the median nerve itself, or to be more precise, it's about the recurrent branch of the median nerve, the $1 million nerve. And we all know and agree that the hypothenar muscles are supplied by the ulnar nerve. And the forearm muscles are almost all supplied by the median nerve, like the flexor digitorum superficialis and the half of the flexor digitorum profundus, as well as the flexor carpi radialis. While the palmaris longus, this muscle, which is more developed in the apes, what supplies the palmaris longus? Yes, it's the median nerve. But do you know the palmaris brevis? The trick in the exam won't be in the palmaris longus, but it will be in the palmaris brevis, which is one of the hypothenar muscles which is supplied by the ulnar nerve. So the ulnar nerve, yes, supplies the hypothenar, but some of us doesn't know the names of the hypothenar muscles, and most of them will be obvious. But the palmaris brevis itself is a more confusing one of them. So the most confusing muscle will be the palmaris brevis, which is supplied by the ulnar nerve in the exam. Take care. While the palmaris longus itself is supplied with the forearm muscles nerve, which is the median nerve. The only muscles in the forearm supplied by the ulnar nerve is the flexor carpi ulnaris, because it's on the ulnar side. And by the way, the flexor carpi ulnaris is the savior and the soldier for the ulnar nerve and the ulnar artery. So it's logic to be supplied by the ulnar nerve itself. And the medial half of the flexor digitorum profunda is supplied as well with the ulnar nerve, while the lateral one is supplied by the median nerve. Hope this made it clear. The median nerve enters from forearm to the hand through the carpal tunnel. And the guy in the canal is the special canal made for the ulnar nerve to pass from the forearm to the arm. It has no relation to the carpal tunnel at all. The ulnar nerve is not related to the carpal tunnel. It's related to its own guy in the canal. The question will be, the ulnar nerve is ulnar to the ulnar artery or not? So yes, the ulnar artery is guarded by the ulnar nerve, and the ulnar nerve is ulnar to the ulnar artery. The ulnar artery is inside, the ulnar nerve is outside. These great surgeons, take care. The radial nerve is from the posterior cord of the brachial plexus, while the radial artery is one of the two ends of the brachial artery. The brachial artery is divided into the ulnar artery and the radial artery. The radial artery starts at the elbow, roughly. So, it has nothing to do with the radial nerve itself. They can meet at some point, but they are always apart from each other. There is no relation between the radial nerve and the radial artery. And always take care that the radial nerve and the ulnar nerve have controversy. The ulnar nerve is behind the condyle medially, and the radial nerve is anterior to the condyle laterally. So again, the course of the radial nerve is very important and very critical, because it might be confusing, because every nerve accompanies its named artery except for the radial nerve. It's apart from its artery. The radial nerve is a continuation of the posterior cord. Again, posterior cord of the brachial plexus, of course. It's from C5 to T1. The nerve arises in the axilla region, and take care, it exits the axilla inferiorly via the triangular interval and supplies the branches to the long and lateral head of the triceps. So the triceps is one of the first of early branches by the radial nerve. And the radial nerve then goes down to the arm, traveling in a shallow depression within the surface of the humerus. It's called after its name, the radial groove. So again, posterior cord and posterior to the axillary artery gives the triceps, then goes to the radial groove, and again it continues its descent, and the radial nerve wraps around the humerus laterally and supplies the branches of the medial head of the triceps. Again, during much of its course with the arm, it accompanies the deep branch of the brachial artery. We didn't mention the ulnar or the radial artery, the brachial artery. And by the way, the brachial artery is the trunk that gives off the radial and ulnar arteries. And by the way, there is no median artery. To enter the forearm, the radial nerve travels again anterior to the lateral epicondyle, while the ulnar nerve behind the medial epicondyle. So again, the radial nerve travels anterior to the lateral condyle of the humerus through the cubital fossa, and the nerve then terminates by dividing into two branches. The deep branch, which is the motor, and superficial branch is the sensory. And all of this in the posterior of the forearm. The deep branch innervates the muscle because it's a motor in the posterior compartment of the forearm, while the superficial branch, which is sensory, contribute to cutaneous innervation of the dorsal hand and fingers. And it almost always masked by the median nerve and the ulnar nerve innervation. That's why the sensory loss of the radial nerve is only like a piece of coin in the snuff box region in the dorsum of the hand, because it's almost always masked by the median and the ulnar nerve. And take care. The whole point and the trick as we begin our discussion that the ring finger is supplied by the three nerves, the median, the ulnar, and the radial nerve. Take care. And why God created the radial nerve? The radial nerve was created to do all extensions of the hand. But take care, the lumbricals are not used by the radial nerve. They are innervated by the median and the ulnar. That's why we can still extend our interphalangeal joints of our fingers using the median and the ulnar nerve when there is a radial nerve injury. Take care. And if we mentioned any injury to the nerve, we have to mention the very famous injury to the ulnar nerve and the ulnar paradox. There is no nerve injury to be mentioned without mentioning the holy ulnar paradox. The higher your injury to the ulnar nerve is, the better the prognosis. You see, the ulnar nerve injury in the forearm or the elbow is better than the ulnar nerve injury distally due to the ulnar paradox. Unlike the logic, you would think that if the ulnar nerve was injured in the Guyon's canal, it would be better than being injured in the, for example, in the posterior side of the medial epicondyle at the elbow. No. This is the ulnar paradox. It will be worse. It's better to be cut off in the elbow than to be cut off in the Guyon's canal. Of course, it will be better if not cut at all, but this is the ulnar paradox. We found that the patient who got their ulnar nerve injured at the Guyon's canal got poor prognosis and more manifesting injury. So, although the prognosis will be better after the repair because it's short term and short size, because from the palm of the hand to the Guyon's canal about 20 centimeter, and we'll hear about 1 millimeter per day, and it will take almost 20 centimeter. We are talking about 200 days to be recovered after the repair. But take care, this will be unopposed flexor digitorum profunda. This will cause more clawing of the hand. That is the ulnar paradox. So more clawing of the hand will be with the ulnar nerve injury at the Guyon's canal. Take care. This is the ulnar paradox. These great surgeons, take care. The posterior interosseous nerve is a branch from the radial nerve. However, it innervates all the muscles of the extensor compartment except for the brachioradialis, extensor cardioradialis longus, and extensor cardioradialis brevis. Those three muscles are purely by the radial nerve itself. These great surgeons, when we mention the tunnels of the hand, we have two tunnels in our flexor regions, the Carpal Tunnel and, yes, the Guyon's canal. The Guyon's canal for the ulnar nerve and artery, and the Carpal Tunnel for all the flexors of the hand, except for the flexor pollicis longus and the recurrent branch of the median nerve and superficial cutaneous branch of the median nerve. But every other flexor and the median nerve will be within the Carpal Tunnel itself. While in the extensor region, we have 6 compartments. Those 6 compartments are 6 tunnels by which the forearm tendons pass from the forearm to the hand. So let's get to memorize them, and they are frequently asked in the exam. For me, I memorize them from the sixth compartment to backward. So let's memorize them together. The sixth compartment. I memorize them from the very far compartment, the sixth compartment, which is containing the last extensor tendon, which is the extensor carpi. We have only one extensor carpi in our hand, and it's on sixth compartment of the hand in the extensor region. In the fifth compartment, you will be amazed that the little finger of our hand has its own canal by which the extensor digiti minimi will pass from the hand to the extension of the digiti minimi. And by the way, this is very special. We have only two fingers in our hand had their own extensor other than the thumb, which is the little finger and the index. But the little finger has its own alone tunnel in the extensor region, which is the fifth tunnel. And amazingly, the fifth finger, which is the little finger, has been in the fifth tunnel with its extensor digiti minimi. So the extensor digiti minimi in the fifth tunnel of the extensor compartment. In the fourth compartment, we will have our extensor digitorum communis, which extending the whole fingers of our hand, accompanied by the extensor indices. And in the third compartment, you will be amazed to find the extensor pollicis longus to extend our thumb. But regarding the very first two compartments, in the second compartment, we have two tendons, the extensor carpi radialis longus and the extensor carpi radialis brevis. We have only flexor carpi radialis, only one, while in the extensor region, we have two extensor carpi radialis longus and extensor carpi radialis brevis. They are in the second compartment. And by the way, the extensor carpi radialis longus and brevis are not as important as the extensor carpi ulnaris. Look at your hand. You use the extensor carpi ulnaris to do ulnar deviation than to do a radial deviation. That's why in our plastic surgery we tend to use the extensor carpi radialis longus in our tendon transfer when we want to do flexion and can't use it. Isn't it amazing to use a tendon to another function? This is called tendon transfer. So let's be back to our extensor compartment. We said that the sixth compartment was extensor carpi ulnaris, then the extensor digiti minimis, then the extensor communis accompanied by the extensor indices, then the extensor pollicis longus and the extensor carpi radialis longus and brevis. Then we have the first compartment of the extensor. The first compartment in the extensor compartment will be having the abductor pollicis longus and extensor pollicis brevis. Take care. Hope this made it easy for you. If I was an examiner, I would trick you regarding the second compartment and the fifth compartment, because those are the tricky ones, as well as the content of the first compartment if you confuse them with the anatomical snuff box. In case you forgot the snuff box and forgot which is which, like is the extensor pollicis longus is within the first compartment or the third compartment, take care. The extensor pollicis longus is very special. It has to be having its own canal with nothing beside it, because it's very important to extend our thumb. So extensor pollicis longus within the third compartment. So what will be in the first compartment? Of course, it will be the extensor pollicis brevis and the abductor pollicis longus. We have longus and brevis within the first compartment. One of them, you will be sure that the extensor pollicis longus is not one of them. So the extensor pollicis will be brevis in the first compartment. So the abductor pollicis, it will be the longest one, because we have already our brevis with the extensor pollicis brevis, because the extensor pollicis longus is within the third compartment. I know you now have a bothering mind with a lot of longus and brevis and a lot of tendons name. You will get them. Just listen to voice notes again and again and look at your illustrated photo and you will get it right. Hope this made it clear. So again, our special tendons will be The extensor pollicis longus in the third compartment, and the fifth finger extensor is the extensor digiti minimi in the extensor fifth compartment, fifth tunnel, while the extensor carpi ulnaris is alone in its sixth compartment, while the extensor pollicis longus again in the third compartment. The first compartment will be having the extensor pollicis brevis because we already put our extensor pollicis longus in its third compartment. So what will be with the extensor pollicis brevis? It will be the abductor pollicis longus. Hope this made it clear again and again and again. In case you forgot as well, you can always put your hand on the table and extend your thumb. This tendon you see is the extensor pollicis longus. You can see it's driving and drifting to go to its third compartment, while the other two tendons forming the snuff box with the extensor pollicis longus, those are going to be in the first compartment. So we have three tendons forming the first and the third compartment. The extensor pollicis longus in the third compartment alone, and the two tendons in the first compartment, extensor pollicis brevis and the abductor pollicis longus. Take care. I know you all hope this longest lecture be a brevis lecture. Hope this make it brevis for you. And you will find that all the extensors of the hand supplied by the posterior interosseous nerve, except for the extensor carpi radialis longus and brevis and the brachioradialis, even the extensor carpi ulnaris, take care. Because remember, in the forearm flexor side, we said that the flexor carpi ulnaris is supplied by the ulnar nerve. But take care. The flexor carpi radialis is supplied by the median nerve. There is nothing to do with the radial nerve. So in other words, we can see that the ulnar nerve, it chose to be in the flexor region, supplying its flexor carpi ulnaris and the flexor digitorum profunda half, instead of supplying its extensor carpi ulnaris, leaving the extensor carpi ulnaris to be supplied by the posterior interosseous nerve. And the same way, the radial nerve, it chose to be supplying the extensor carpi radialis longus and brevis as well as the brachioradialis, leaving its flexor carpi radialis to be supplied by the median nerve. Life, it's choices. There is no one getting everything. Everyone has to choose what to take and what not to take. But spend as much as possible power you have to take what is after your name. The radial nerve is extensor nerve. It chooses to supply its named extensor carpi radialis longus and brevis in the extensor region where it has to be. The same way the ulnar nerve, it is for about flexion. That's why it came in the flexion region and kept its extensor carpi ulnaris to be with the posterior interosseous nerve. Life is a wisdom. Live your own wisdom. The amazing thing in the hand, there is much details in every portion of the hand. You can find every finger having at least 5 annular pulleys and 3 cruciate pulleys to keep the tendons in execution so that the flexor tendons doesn't pull while flexion. Isn't it amazing? To add another detail, do you know that we found that in our extensor region we have 9 zones, while in the flexor regions we have mainly 5 zones, and the 9 zones are more easy to be remembered than the 5 zones, because in the 9 zones of the extensor regions you can number it from the even and the odd, and start the odd numbering at the joints from the distal interpharyngeal joints. So it will be the distal interpharyngeal joints number 1, and go watch your hand and put the other odd numbers on the joints, and you will get it. And the best result is being in the zone number 6, between the zone number 5 and zone number 7. And now see your hand and tell me which is this zone number 6, which all plastic surgeons love. While the flexor regions of the hand are 5, they are starting from the very insertion of the flexor digitorum superficialis to the very insertion of the flexor digitorum profunda. And we all know that the flexor digitorum superficialis is insertion at the base of the middle phalanx, and the flexor digitorum profunda is inserted as the distal phalanx base. This is the first zone. And the second zone will be, yes, it is from the A2 poly until the insertion of the flexor digitorum superficialis. Then we have the third region from the A2 to the beginning of the carpal tunnel. And the carpal tunnel itself is the A4, is the zone number 4. This is the carpal tunnel. It is zone number 4. And below the carpal tunnel, this will be zone number 5. Those zones are not essential for all of you, but if any one of you is plastic surgeon, he will enjoy this one. Hope you enjoyed it too. These great surgeons, the carpal tunnel syndrome is very important, and you have to understand the carpal tunnel anatomy in order to understand the carpal tunnel syndrome. The boundaries of the carpal tunnel posterior border will be the carpal bone, and the anterior border will be the transverse carpal ligament or the flexor retinaculum, and the boundaries will be proximally the pisiform and the tubercle of the navicular bone, while distally will be the hook of the hamate as well as the tubercle of the trapezium. The contents of the carpal tunnel will be the flexor digitorum superficialis, flexor digitorum profunda, flexor pollicis longus, and the median nerve. Of course, the recurrent branch of the median nerve is above it, and the superficial branch of the median nerve, the superficial cutaneous branch, is above it, and the ulnar nerve and the ulnar artery within the Guyon's canal away from the carpal tunnel. So the carpal tunnel syndrome, due to the entrapment of the median nerve, due to many reasons, will be within this anatomy. You can always test for the carpal tunnel syndrome using tunnel test and Fallon test, while testing for the ulnar nerve will be Fromenkart test. These great surgeons take care carpal tunnel syndrome more frequently to be presenting in females between the age of 40 and 60-year-old age, and never underestimate a patient female. So, what other causes that can predispose to carpal tunnel syndrome? Myxedema, rheumatoid arthritis, acromegaly, multiple myeloma, nephrotic syndrome, amyloidosis, even diabetes mellitus, and pregnancy. And by the way, in the exam, it will ask you about a pregnant female who didn't control her hand and hand grip. This is due to the loss of the opponent's by the compression of the median nerve, as well as the myxedema and the acromegaly. Those are the most frequent questions in the exam. The myxedema, acromegaly, and pregnancy. He will tell you something related to the signs of the carpal tunnel syndrome due to loss of the hand opponents, as well as the gout and pseudo-gout, lipomas, obesity, menopause, alcoholism, wrist fractures. All of those can predispose to carpal tunnel syndrome, compression of the median nerve. But I will want you to focus on the myxedema, acromegaly, and pregnancy. And in real life, those are the most common scenarios, as well as the fractures, of course. A man who got a fracture, he might got carpal tunnel syndrome later on.